I will continue with you the second part of the lecture, which is about antenatal screening. Screening is a process of identifying apparently healthy people who may be at an increased risk of a disease or condition that may affect the mother or the fetus. The screening is done for all pregnant women. For example, we are screening for gestational diabetes. We want to screen for hypertension. So, as we say in the previous lecture, we should measure the blood pressure for all pregnant women, even if this woman don't have history of hypertension or any risk factor for hypertension. But why we screen for hypertension and diabetes in all pregnant women? Because first of all, they are common conditions and they may have an adverse effect on the woman or on the fetus. So, in the process of screening, we will do the screening for all the population, and then we pick up 1 or 2 persons who are at higher risk of development of this condition, and then we will apply a diagnostic test on them. After that, we will advise them, give them support and treatment. The aims of screening, first of all, to allow risky women to have diagnostic tests. The second thing is to allow counseling of the parents about the disease, the impact of the disease on the mother and her fetus, and counseling about termination of a pregnancy. And here we don't doing it for religious purposes, but outside they do termination of pregnancy. The third aim is enabling time for medical or surgical intervention to decrease the morbidity and mortality. And 4, prepare the family emotionally, financially, and socially for the born child. For example, child with congenital anomaly. Certain congenital anomalies that should be treated just after delivery. So we should diagnose it before delivery, for example, by anomaly scan. So we should advise the woman to get pregnant in a tertiary center to have the intervention and the surgery done immediately to her newborn. Principles of screening. Shall we do the screening for all the diseases that we read about it? No. The screening should be done to a condition of high prevalence and a significant health problem. This is first. And the natural history of the disease should be known. I should know, for example, the outcome of a patient, for example, with hypertension, and I know the complications that may occur. There must be mechanism of a prevention and the treatment of screen positive patients. If the patient, for example, by screening, we know that she's at increased risk of developing hypertension, we can screen for hypertension by history or by measurement the blood pressure. So if we take history from the patient and, for example, she gave us an information that she have history of pregnancy-induced hypertension with her previous child. So when she gets pregnant, we should prescribe for her aspirin, which is a preventive measure. Aspirin will decrease the incidence of development of hypertension, and if the hypertension develop, the complication will be less on the mother and on the fetus. The screening test should be sensitive and acceptable to the patient and cost-effective. The measurement of blood pressure is easy. Doing random blood sugar is easy. Screening for infection, for example, that is easy. General urine for asymptomatic bacteriuria, whatever. So the screening test should be less invasive as much as possible, and cost-effective. And every disease that we screen for it, we should have a diagnostic test. These principles of screening are applied to all disease in medicine, not just during pregnancy. The same principles, the WHO principles of screening are applied to all the diseases, not just during a pregnancy. So, what are the diseases that we screen for during pregnancy? First of all, screening for hematological conditions, and the commonest one of them is anemia. All pregnant women should be offered screening for anemia by doing CBC, and the CBC should be done in the booking visit. If she has risk factor, we should repeat it in each visit. And the other time, which is very important, is at the 28 weeks of gestation. The second hematological condition that we should screen for is the blood group and red cell autoantibodies. Women should be offered testing for blood group and RSD status in early pregnancy. So, if the patient is diagnosed as Rh negative woman and her husband is Rh positive, we should give her routine antenatal anti-D prophylaxis at 28 weeks of gestation if she is non-sensitized and she don't have any antibodies in her serum. The third hematological condition, which is the hemoglobinopathies, sickle cell anemia, and thalassemia. Testing should be available to all women who are identified as being at high risk, either using the family origin questionnaire or according to her CBC result. We offer the screening for sickle cell thalassemia usually between 8 and 10 weeks. If the pregnant woman is identified as or known to be a carrier, we should offer the screening to her husband as soon as possible. And if the pregnant woman and her husband are identified as carriers or affected, we should refer for counseling and offer prenatal diagnosis by 12 weeks and 6 days of pregnancy to know whether her carrying fetus also affected by this disease or not. The other thing that we should screen for during a pregnancy is the structural anomalies of the fetus. And as I told you, we should do anomaly scan between 20 and 22 weeks of gestation to all pregnant women to screen for these anomalies. Fetal chromosomal anomalies, Down, Edwards, and Patau syndromes, we should screen for them. And the commonest one is Down syndrome. There is many tests for the screening of Down syndrome. We have the combined test, the triple test, the quadruple test. Some tests are doing during the first trimester and others in the second trimester, in addition to the nuchal translucency measurement of the dating scan. The combined test is the commonest one, and the optimum time for screening it is when the fetal crown rope length is between 45 millimeter and 84 millimeter, which equates to 11 to 13 plus 60 weeks of gestation. Now, at time of the dating scan, we measure the nuchal translucency and we doing combined test for the woman, which is a blood test. And in addition, we should put in our mind the age of the woman, because if her age is more than 35 years, she's at an increased risk of having a child with Down syndrome. Infectious diseases in a pregnancy, we should screening for HIV, hepatitis B, syphilis, and we should know the rubella status of the woman. This should be done early in pregnancy, because if the patient have HIV, it will be a high-risk pregnancy, and we should manage her especially. Also, if the patient have hepatitis B, syphilis, or rubella. Babies who are born to hepatitis B positive mothers should be vaccinated just after delivery, in addition to addition of immunoglobulin within 12 hours of birth, and referred for follow-up on vaccination schedules at first and 6th month of age, with a blood test for infectivity status. We reach to the end of our lecture. This is a graph which shows to you the summary of all the 2 lectures about antenatal care and antenatal screening. As I told you, we should see the patient in a preconception clinic to know if she have any risk factors. For example, if she have diabetes, history of diabetes or hypertension, or if she's already hypertensive woman. So her medical condition should be optimized before pregnancy, and we should prescribe for her folic acid. Then, if she get pregnant, we do for her the first contact, and then the dating scan and the booking visit, screening for hematological disease. We should do for her CBC to know her hemoglobin level, and her blood group and RH also should be known for us. This is the screening for Down syndrome here at this gestational age by combined test and by ultrasound. Then in the second trimester also there is tests for Down syndrome, the quadruple and the triple test done at the second trimester, in addition to the anomaly scan that should be done for these women. At 28 weeks, we should see the patient, repeat for her hemoglobin level and the antibodies if she's Rh negative, and also the random blood sugar. Then, when the patient, at the end of her 8th month of pregnancy, we should discuss with her the delivery plan and the place of her birth. I hope that the lecture was clear for you, and I am ready for any questions you have in the classroom and in the meeting if the good will. And thank you for your listening.